going to talk about medications that affect bleeding, specifically medications that stop clotting or anticoagulation medications. In order to understand how those medications work, you have to understand what happens with clotting, because that's what the medications are going to manipulate. So the first thing we're going to talk about is the process of hemostasis, which is how the body stops bleeding. So if there is any kind of tissue injury, platelets, that are those little fragments that are normally going through the bloodstream, when exposed to an injury, become activated. So instead of being that little cell fragment, they get little spidery spines and have the ability to be more sticky. So that's the first part. Then these kind of spidery, sticky platelets start to adhere or stick together. So the second step after activation is adhesion. So there are receptor sites on all the platelets that are exposed that allow them to get stuck together with fibrinogen, which is also circulating. So these little strings hook all the platelets together because they can hook together on these exposed receptor sites. This injury also triggers the clotting cascade, and at the end of the clotting cascade, the very bottom of that, is the production of fibrin. Fibrin is the end of the cascade, and fibrin is stronger string. So we can make the clot strong, kind of sew it and make it as strong as possible. So the steps to hemostasis are platelet activation, platelet adhesion and aggregation, which means they clump together, and then strengthening of the clot because of the production of fibrin, which gives us that nice, strong platelet plug. Eventually, over time, once the area that was previously injured is healed, then we can get rid of the clot, and the body has a process for doing that. It uses tissue plasminogen activator to activate plasminogen to break down any clot that was formed. And it is these checkpoints, activation, aggregation, clot strength with fibrin, that are medication targets for anticoagulation. So the first medication we're going to talk about is one that we've already talked about. So this should be just a review. We talked about it in terms of its anti-inflammatory properties because you can use it for pain and fever reduction. But aspirin is also a medication that prevents clotting because it irreversibly binds to platelets for the life of the platelet. So that's for a full 7 days. So normally, in response to an injury, platelet will become activated, sticky, and spider-like. If aspirin is on it, then it can't do that. So we can't have the beginning of the clot. So if you take baby aspirin, which is 81 milligrams daily, you're preventing clot formation. Because people that have lipids, atherosclerosis, are prone to activation of platelets just because those are present. So you want to prevent that. So who needs to take 81 milligrams of aspirin daily to prevent clots? Someone that has a history of elevated cholesterol, because that puts them at risk of developing clots. And so that's the people that are at risk of MI or stroke that will be prescribed aspirin. So how do we know that it worked? Well, the only way we know it worked is because they don't actually get a clot. There's no blood test that we can check though, because it doesn't change the number of platelets. It just changes how the platelets work. So we have a patient that's at risk of MI or stroke, especially if they have elevated cholesterol. So we tell them to take a baby aspirin daily to prevent that risk. But we know that aspirin also is a COX-1, COX-2 inhibitor, so it increases the risk of stomach ulcers and kidney issues. So they should take it with food or an enteric-coated one, or take it with milk, and watch your kidney function. And we know that it decreases pain and inflammation and fever, which is why people took it before. But it also had some other things that we worry about, like salicylism if you're taking too much, but just taking this daily shouldn't do that at all. And hopefully we're not dealing with a child or anyone that's under 18 needing to take prophylactic aspirin, although it is possible, I guess. So that's aspirin. So say the patient has already had an MI or stroke, so they've shown that they have the possibility of clotting, and maybe they've had an MI and had a stent placed, so they're at increased risk of clot where that stent was already placed. They will take a medication that's going to be a little bit stronger or decrease clotting a little bit more instead of aspirin, and that potential medication is Clopidogrel, which is Plavix. The way this medication works is by blocking the receptors that are exposed on activated platelets, so they can't bind together because there's no receptor sites that are open for them to bind. So if I'm taking this medication, it's because I've already demonstrated the fact that I do make clots, or I have a stent that needs to be protected, and I don't want the platelets to adhere to each other. There are times when people take aspirin and Plavix together, but it's not very common because the risk of bleeding increases because you're on both. They would have an additive relationship. You wouldn't be able to lower the doses of either of them, but they certainly would increase the risk of bleeding when taken together. You will sometimes see patients with those medications together if they've had multiple MIs or have multiple stents that have failed. So this pill, you don't crush it or split it. It's PO. It does have some side effects that are listed there. Flu-like syndrome, headache, dizzy, can get some itchy rashes. The biggest side effect that can become adverse effect, depending on how severe it is bleeding. So the patient should be counseled on ways to prevent bleeding, such as avoiding full contact sports, using a soft bristle toothbrush, using electric razors, using a water pick, things that we do to decrease the risk of bleeding. So those were medications that affected platelets. Again, both of them are indicated depending on clot risk. There's no blood tests to monitor their effectiveness because they don't change the number of platelets, they change platelet activity. So the only way we know they worked is the patient doesn't have a clot. So now we're getting to medications that will affect the clotting cascade. So that's the second part, besides activation of platelets, is developing or getting to the thread that will help make the platelet clump stronger to fully form that platelet plug. So we can try to decrease the production of the thread. That's the other way to do this. And we can do that by changing how clotting factors are made with either heparin or warfarin. So heparin binds to antithrombin 3, inactivating several clotting factors, and that occurs upwards in the scale, whereas warfarin changes the production of clotting factors to begin with. So in order to fully understand their exact activity, you do kind of have to understand the clotting cascade itself, which is multiple steps from the point of tissue injury. Activation of clotting factors, one factor causes activation of another factor, which causes activation of another factor, which causes activation of another factor. And there are two pathways, an internal and external pathway, but they both have the same thing in common. That's the final common pathway, which is a thrombin burst, where prothrombin changes to thrombin, and thrombin is what changes fibrinogen to fibrin, which is the thread. So heparin can be used to slow this down and decrease the number of thread and decrease clot strength by binding to several of the clotting factors so that they become inactive. And it works immediately if you give it IV. It takes about an hour to work if you give it subcutaneous. It has, once you stop it, it takes 6 hours for it to leave the body's system. The biggest issues with heparin is that that'll, of course, increase the bleeding risk. So that could be a side effect all the way up to an adverse effect, depending on how severe the bleeding is. There are some people that will get an autoimmune reaction to heparin, which will cause them to decrease their amount of platelets. So that's not very common. Oftentimes, if people are in the hospital and either they had an epidural to decrease pain after a painful abdominal surgery, you have to be careful about them. You have to hold the heparin before an epidural is placed or removed, or you can develop something called a subdural hematoma, which could cause paralysis. If someone overdoses on heparin or their PTT gets too high, then you can give them an antidote, which is protamine. The inpatient setting, you'll see people receive heparin two ways. You can't give heparin orally. You can give heparin as a subcutaneous injection or as IV. In the hospitalized setting, people will often give patients heparin subcutaneously or Lovenox, which is similar to heparin subcutaneously, at lower doses in order to prevent a clot in a high-risk hospitalized patient. So being in the hospital in and of itself, being sick, having a surgery, being immobile, those are all reasons that people can develop a clot. And because it's so frequent, we try to prevent it. So as you'll see, if you've had any clinical time in the hospital, anytime you have a patient who has had, who is immobile or hospitalized, they will be on subcutaneous heparin or Lovenox. If this is what they're on in order to prevent clots, there isn't a blood test that's done to be sure that it's working. The way you know it's working is they don't have a clot. This dose is too low for it to affect the blood tests themselves. So I know the patient doesn't have a clot. So the kinds of clot I'm trying to prevent in a hospitalized patient is a DVT or a PE. So if my patient has a DVT, they will have asymmetric swelling of the legs. So one leg is swollen, red, potentially painful because the clot's there. Or if that clot that started there travels to the lungs, they will have acute shortness of breath, cough, potential tachycardia, low oxygen level. So I know that this worked only because they don't have a clot. And that's always a test question. So here's this patient that had this, that's hospitalized. I'm giving these subcutaneous injections. There are no blood tests to show me if it's working. What shows me that it's working is they do not get a clot while hospitalized. The other way to use IV heparin or higher dose subcutaneous Lovenox is to treat an acute clot. So if I'm doing this with heparin, it's an IV infusion. The patient will continuously be getting a dose of heparin through their IV, and it's based on their weight. And the lab test that we're watching is called the PTT, or partial thromboplastin time. What that is how long does it take to get to a certain point in the clotting cascade? And if the heparin is working, it should take longer, because we want it to take longer. We want them not to be able to form clots. We want them to be more prone to bleeding. So if I give someone IV heparin, I don't expect that I will cure them of the clot. The clot that's there has to be broken down by their body. What I am doing is preventing the clot from getting larger or causing more problems. This is the math portion of our exam this time, and it can be a little bit difficult. There is an example of the math in the math section that you see, just to see how you guys do, to give it a try and see how that goes, so that I know exactly how much I need to do extra teaching. Because usually what happens is the patient will be placed on this IV heparin infusion. They'll be given a bolus from a vial. You pull it up from a vial and you shoot it into the IV in the very beginning. and then they're placed on a continuous infusion of heparin until the doctor says not to do it anymore. And it's based on their weight. So then 6 hours later, after you start this medication, you'll check this PTT to see what level it is. The therapeutic range is 50 to 70 seconds. If it's lower than 50, then likely the drip or the infusion will have to be increased. If it's higher than 70, the drip will have to be decreased. You're trying to maintain this level. And so that is how the questions will be on the exam. So you have a patient, maybe they're being treated for an acute pulmonary embolism, they're on weight-based heparin protocol, they're getting the infusion, you see their PTT level, what's the range, and how do I adjust my infusion? And that's what the practice question is for the math, to see how you do with it. And we'll look back at it if we need to, because that'll definitely be on the exam. Some other things to worry about with heparin, like we said, so either of these people, the hospitalized patient who is on subcutaneous heparin, if they had a major abdominal surgery, they might have gotten an epidural placed prior to surgery in order to maintain their pain. So these are definitely people that we'd have to be sure to hold this so they don't get an epidural bleed, which could lead to paralysis. And both of these patients, we want to be sure that they're protected from bleeding, so we have to be careful with them. And this patient, especially the one that's on the IV treatment, if it gets too high, the reversal is protamine. Patients who are at very high risk of clots, maybe they have AFib, which increases clot risk, or they've had a clot before, they had a DVT or PE, and so now they needed to be on Warfarin, something like that, they're going to be on a continuous. So this medication, Warfarin, that's a generic name for Coumadin. What it does is it blocks vitamin K. Vitamin K is used by the liver to make clotting factors. And so if I block the available vitamin K, then I can't make the clotting factors. So this takes a while to work. I can't give it instantly like heparin and expect it to work. It might take 4 to 7 days, sometimes even longer to work. It can take up to a week. And it's very patient dependent. And it has multiple medication interactions and food interactions. So people who start Warfarin should maintain a consistent vitamin K intake. If they increase vitamin K, then their dose of Warfarin will have to increase. If they decrease vitamin K, then hold on a second. Sorry, my dog is very bored on quarantine. So, if the patient decreases their amount of vitamin K intake, then the Warfarin dose might have to be decreased. So they should leave it as it is. The biggest risk, of course, would be bleeding. We have to be careful with people that have wounds because it can decrease wound healing. It can, if people have any sort of liver or kidney problems, it'll metabolize differently. If they end up with an overdose, then they can take vitamin K as the reversal. So what we're measuring to see if it's effective is INR, which is an international ratio. It is a simple way that everybody responds to or looks at. It's essentially coinciding with the patient's prothrombin time, or how long does it take them to get to that prothrombin to thrombin phase of the clotting cascade. And we want it to take longer. That means that they're clotting less. So normally a person's INR is 1 to 2. If they are at increased risk of clot, have had a clot, we would want their range, their INR range, to be 2 to 3. Anything greater than 3, then we worry that they're going to be at increased risk of bleeding. Once they get to 4 or more, their risk of spontaneous bleeding increases, and they might be given an antidote. So this is what we want for treatment. If the patient's INR gets below 2, then it's not high enough for somebody that needs that protection. So teaching points that you'll see there, we have to worry about how the medications are given, subcutaneous, how we can protect from injury people that are on medications that cause bleeding. What food do we have to worry about? What's vitamin K, especially for warfarin? And how do we know the medication is working? Some medications have blood tests and some don't. And that is what quiz 5 will be about. So review that. The last part of this lecture is the one medication that is a clot buster, a thrombolytic. That medication is a thrombolytic, and ours is alteplase, which is TPA. It's a tissue plasminogen activator, meaning it activates plasminogen in the body, and plasmin is what breaks clots down after healing has occurred. That's how it would normally do in the body. We can use it in the acute setting of an acute stroke or acute MI in order to get rid of that clot and open up circulation. But there's a lot of rules with this medicine because once you give it, you kind of have to live with the consequences. You want to open up a blood vessel so that blood flow is improved. However, there's no antidote. So the time that this medication is in the body, there's nothing I can do to stop bleeding in the body. So there are a lot of rules about how and when to give it. So the first thing you can see there, it says within 12 hours of an MI or 3 hours of a CVA. So if you don't know when the patient first started having their symptoms, you can't give it. You put the patient went to bed, your mom went to bed, you woke up and she couldn't talk. Who knows? It could have happened 5 minutes ago, but it could have happened 8 hours ago. So they wouldn't be eligible. And we have to be sure that there's no contraindications to that. If there's something in them that might bleed, we only want to break down the clot that's present. We don't want to cause bleeding that we can't control. So there's contraindications. Any history of head injury or stroke in the last 3 months, because that area would have clotted. And if we give this medication, we can cause bleeding. Recent history of surgery or trauma, especially within the last 3 to 6 months. Severe uncontrolled hypertension, because they're prone to intracranial bleeding. Intracranial cancer or AV malformation, which is a weird sort of weak vessel like an aneurysm, could also cause bleeding, because once you give it, for the 3 hours that you gave it, there's nothing you can do to stop bleeding. So there's always a question on a test, like, okay, someone has a clot after a recent surgery, why can't they get it? Well, because the surgery itself, in order for the surgeon to be done, we have to have clot formation. Otherwise, the patient will keep bleeding. So then the patient has a knee surgery, which puts them at increased risk for clots. They have a stroke. We give them TPA. They're going to bleed continuously from their knee, and there's nothing we can do to stop it. So other things to remember is we want to do all kind of invasive procedures before the infusion. So any IV lines, Foley catheter. Patients shouldn't be getting out of bed. They have to use a bedpan. We should be using manual blood pressure cuffs instead of automatic cuffs because they get really, really tight and that might injure the patient. So we have to be very careful with them.